All right, if you've ever found yourself wondering why the global healthcare system is practically running away from traditional medical billing, well, you're in exactly the right place. Today, we're going to unpack the actual financial algorithms that dictate how hospitals get paid, how they operate day to day, and ultimately how that impacts the treatment you receive. Here's how we're going to break this all down today. We'll start with the fee-for-service flaw, then define what a DRG actually is, and look at how they work in practice. After that, we'll explore DRGs as a global fiscal instrument, touch on how people try to game the system, and wrap up with the value-based future. So let's jump right into part one, the fee-for-service flaw. Now, think about the old fee-for-service model. It's essentially an a la carte menu. Hospitals literally charged for every single test, every scan, and every little pill. Obviously, this naturally incentivizes volume and, unfortunately, overtreatment. The DRG model, on the other hand, is kind of like a fixed-price meal combo. The hospital gets one set amount for your specific condition. It completely flips the script and incentivizes efficiency instead. And just to put the sheer scale of this into perspective, the Centers for Medicare and Medicaid Services projects that payment rate changes are going to increase Medicare hospital payments by a staggering $5.0 billion in fiscal year 2026 alone. Yeah, $5 billion. When you've got billions of dollars on the line like that, the payment mechanism dictates absolutely everything. Which brings us to part two. What exactly is a DRG? Simply put, a DRG, or diagnosis-related group, is a prospective payment system. By grouping patients that have very similar clinical profiles together, the payer just hands the hospital a single fixed fee up front. The real genius here, or maybe the catch, depending on how you look at it, is that it shifts the financial risk completely away from the government or the insurer and drops it squarely onto the healthcare provider. Moving on to part three, how DRGs actually work. Assigning a DRG isn't just guesswork. It requires incredibly meticulous coding. First, in step one, a patient is assigned to a broad major diagnostic category based on clinical similarities. Then, step two classifies the hospital stay as either surgical or non-surgical using specific procedure codes. And finally, step three refines that grouping by factoring in things like the patient's age, any comorbidities, and complications. All of that combined calculates the final payout. It's actually pretty amazing to look back at the very first generation of Medicare DRGs from 1976. Back then, there were just 83 categories. But the system has constantly evolved. Today, we're looking at these highly refined international groupings that precisely account for things like mortality hazards and super granular case complexities. Let's dive into part four, a global fiscal instrument. Because, you see, this is definitely not just an American phenomenon. While the U.S. is busy iterating toward value-based purchasing, other nations are absolutely sprinting with the DRG framework. Take China, for instance. They're undertaking this massive, top-down transition across various pilot cities right now, all to achieve universal health coverage. It really proves how adaptable this fiscal instrument is globally. And the results? Honestly, they can be staggering. During early pilot testing in Germany, they saw a massive 35% reduction in medical costs, alongside a 30% shorter average length of stay. For the first time, hospitals were financially incentivized to heal patients efficiently rather than just keeping them in beds to rack up daily room charges.
But of course, that leads us right into part five, gaming the system.
Whenever you set up rigid rules, people are going to test the boundaries, right? Because hospitals now view extra services as a drain on their profit, some definitely attempt to game the rules. We see things like aggressive upcoding, literally pushing to put patients on ventilators just to trigger a higher-paying tier. We also see premature discharges or even dangerously cutting corners on necessary medical care just to pad those profit margins. So that brings up a really fascinating modern complication. As hospitals increasingly turn to AI to optimize all this complex coding, we have to ask, are we actually fixing the administrative burden, or are we just automating a brand new arms race between payers and providers? Well, recent analysis paints kind of a worrying picture. It turns out that AI-enabled coding is actually increasing billing intensity right now. So instead of streamlining healthcare like we all hoped, it's risking massive medical cost inflation through this endless automated back-and-forth battle between the hospital's AI and the health plan's AI. All right, final section. Part 6, the value-based future. To counter all these risks, CMS introduced the Hospital Value-Based Purchasing Program. It's a really clever pivot. Basically, they withhold 2% of that base DRG payment upfront, and they only redistribute it back based strictly on clinical outcomes, safety, and patient experience. Meaning, you don't just get paid for treating someone anymore, you get paid for treating them well. And this accountability, it's expanding way beyond the hospital doors. Starting in 2026, the CMS Transforming Episode Accountability Model, or TEAM, is going to legally tie a hospital's reimbursement to a patient's holistic recovery for a full 30 days post-surgery. So if you're the hospital, you are financially on the hook, even while that patient is resting and healing up at home. Which leaves us with a pretty critical question to end on. As global healthcare makes this massive shift from volume to value, we really have to ask ourselves, are these financial algorithms ultimately going to heal patients better, or are they just engineered to protect the bottom line? It's something we absolutely need to keep questioning as these systems continue to shape our world.